so happy to see all of you. I'm going to take 1 second to just tell one thing that's been kind of on my mind lately, which is this metaphor we've been using about the marathon that we're on, and we just crossed the first line, right? And recently I was thinking a lot about the Crisis Jam, and I wrote David Covington about an idea I had, and his response was one line, which was keep running. And I was thinking about that over the last week, about how, in preparation for the date for 988, we were making sure we had the right shoes and that our clothes didn't rub us the wrong way and that everything was kind of in line. And now that we're going, some of us are on the sidelines cheering us on as we're kind of feeling a little tired. Some of us are handing out water. Some of us are blocking the roads to make sure the course is clear. And I think just his saying to me, keep running, is just the perfect thing for the Crisis Jam. Let's just keep running. So with that, we will get started with today. I wanted to start by just giving a little preview of what we're going to hear about today, which is what does supporting those at risk of suicide on a call, a text, or a chat really sound or look like? And we're going to find out a little bit more in detail about that today. As you know, we've been reviewing every week sort of who's on the jam and who's listening to what. We still haven't beaten the one with Miriam Delphin-Rittman, hosted by David Covington, the one in the pink on the right. But what I want you to notice is, look at the YouTube watches are catching up to those people who are on the live. So let's keep going. We are almost 3,000 strong at this point. And if you're part of a national organization and you don't see your name on the left, let us know. We'd love to add you to the sheet on the left. Maybe we can make it so big that this will end up being 2 slides, a slide with the national organizations and the slide of our top sessions. Remember, you can always visit us at talkcrisisnow.com. If you'll notice here, this picture of the front page over on the left, you see we have a new place called Promote 988. We're going to have a lot of little things in there, the t-shirt ordering, backgrounds that you can use, all kinds of things to help get the word out that you're part of this group who's running forward with 988. And I'll just remind you, my husband this morning ordered his own shirt, which is pretty amazing because he works for a totally different industry. Remember that money helps support the operations of this call. It helps get the ASL translators, et cetera. So it's really a good thing. It's a good use of your money and a good way to promote what we're doing here. Remember also that on the jam sheet, you can find out, what's coming up, what's been on here in the past, who's coming up. And so it's really important to take a look at the website every once in a while. I know I go to it often. Now, if you're like me, and one day you were like, wait, my Wednesday looks really open. I got all kinds of time. And I was like, wait, something's wrong. I'm missing the jam. So if the jam has fallen off your calendar, we have it. We're going to put the link in the chat, how to find it. And also it's in the newsletter that comes every week. When you look at that in the newsletter, it's not to sign up for the newsletter, which you can certainly do, but you're probably already on, but it has the link to download to your calendar because your Wednesday mornings are not as open as you thought. You want to be on the jam. So if it's fallen off, please revisit. So we're moving things around a little bit today, and I'm inviting Stephanie to come forward and talk to us a little bit about your recent interview with Rob Morrison.
Thanks, Amy. Yeah, so I'd like to welcome Rob Morrison. He's the Executive Director and Director of Legislative Affairs at the National Association of State Alcohol and Drug Abuse Directors. Rob, if you're on the call, if you could chat a little bit, in our conversation, what really stood out to me is how vital it is for explicit inclusion for substance use disorders in legislation. If you could talk a little bit about why language matters and the pitfalls of lack of explicit inclusion.
Stephanie, and thanks for the work of this group And it was fun to see so many folks celebrate the launch of 988 and the implementation side at the Association of State Mental Health Program Directors event. I want to recognize Brian Hepburn for having a nice time to reflect because of all the work. Sometimes you don't do that. So it was nice to be able to do that. Number two, as Stephanie indicated, she reached out to talk about the impact of 988 and the work that's being done and the challenges as well. And what I talked about was the benefits in legislation and regulation of being precise. And that is to say, umbrella terms are fine, I think, in everyday language, but when it comes to legislation, the precise point is to be precise. So that on the back end, when people work to develop regulations, the intent then is very clear. It's screamingly clear about what folks are after. And then the federal agencies can work with an eye on that specificity. So in this case, we know that there was a desire to help promote an easier pathway for people to dial in to get help. And of course, we strongly support that. I think what was missing were specific references if it was designed to help reach folks in crisis from substance use disorders. There was an absence of references in the legislation in particular to substance use disorders. And things happen quickly on the Hill. Things happen at lightning speed. And in the end, I think it's something we can all work together on as we look to implement. As you all have said, it's a long road. And so when we look at things like staffing, when we look at outreach, when we look at referrals, when we look at service delivery, when we look at stakeholders, all those things combined are opportunities to expand our reach and to be more precise about messaging that helping people on substance use disorders, people with substance use disorders who are in crisis, our target audience. But it happens at the kernel of this work, and that kernel was the legislation. So what we're doing is helping just promote this as a wonderful opportunity. I want to thank you again, Stephanie, and this group for all the work you're doing, because we also don't want to we don't want to have something that will expand our reach be perceived to be a knock on this work or negative at all. This is something to help continue to remind ourselves and keep an eye on, and especially with future statutory efforts to be precise and to say what we mean and mean what we say, and that is to include specifically substance use disorders as opposed to other catch-all terms, especially again when it comes to statute and reg. So thank you, Stephanie.
Thank you so much for hopping on the call with us. Back to you, Amy.
Thanks so much. And again, I think these terms of behavioral health, et cetera, we need to be more explicit. So I really appreciate you pointing that out, Rob and Stephanie, for bringing that forward to the group. So just a couple recent news things. I'm sure you've seen them, but just to remind you, Washington Post had an article this week on the 988 hotline could be transformational if done right. Then there was another article from the HHS secretary in MedPage Today saying governors have got to own this. And lastly, another article from this week was in AP. The new 988 hotline doesn't currently use geolocation services. And this really was a help to us because a lot of misinformation was going around. So I know we're happy to continue to be in the news and be at the top of the news around 988. It certainly does help us. So our quote of the week comes from two of our speakers, Eduardo Vega and Dr. John Draper, who are going to be our featured speakers today. And here's one of their quotes. Often, many mental health professionals have narrowly focused on identifying persons at risk and getting them into treatment. Conversely, many mental health consumer advocates either avoid or react negatively to suicide prevention discussions, at times due to traumas associated with historically coercive practices and policies. This resource may enable these two powerful forces for change to come together and develop new, more effective approaches to reducing suicide attempts and deaths. And so now I want to turn it over to Dr. Draper to introduce the team and to talk to us a little bit about engaging and helping persons at imminent risk.
Thank you, Amy. It's great to be here with you all. I'm also joined by my friends and colleagues, Eduardo Vega, who's the CEO of Humanovations. Eduardo is also the founding chair of what was called the Consumer Survivor Subcommittee, now the Lived Experience Committee, one of 3 national advisory groups to the Lifeline, has been doing that. And it's been our steering committee for 17 years. And then Shye Louis, who is leading our efforts in standards training and practices, the Lifeline currently. We can go to the next slide. And this is to note, this is me, not Samson speaking. We can go to the next one too. So going back about 2 decades, when the first grant for networking and certifying hotlines was put out by SAMHSA, there were really 2 major goals embedded in that. The first one was making sure that we could network hotlines so people could be easily reached and connected to care around the United States through a 1-800 hotline. The other thing that was really important was to determine whether or not this works. So if we're going to be putting out taxpayers' money, let's make sure that hotlines are actually effective in doing what they're supposed to do. And so SAMHSA made sure that these evaluations were done, and to this day are being done on the hotline. Initially starting with these evaluations was Dr. Madeline Gould, the late great Dr. John Califat, and Dr. Brian Mishara, each doing what we would describe as hotline outcome studies and hotline processes study. So what people were doing and how they were they effective or not? And we did find through those findings that that in most cases, people were feeling better by the end of the call. Emotional distress was reduced, and so was suicidality. We also found there's some things we could be doing better. We needed to do a better job of risk assessment. We also needed to follow up with people who were still at high risk after the call. And we also found that there was wide variation among the crisis hotlines to the degree that they were deploying emergency services, for example, when people were dying. And we thought we've got to have more standards, more uniform policies and practices to make sure that the experience is uniform for people who are in distress across the country. Go to the next slide, please. So our process for doing that has always been driven by research, have our committees, Standards Training and Practices Committee, our Lived Experience Committee, our Steering Committee, identify what those best practices are, establish those standards and guidelines, implement them across the country, train and provide technical assistance around them, and then evaluate them again in this iterative process that is perpetually iterative and is to this day. And we are learning as we speak about what are the best ways to help people. Let's go to the next slide if we could. Now, the first thing we thought we needed to do was make sure, as the National Suicide Prevention Lifeline, to do a better job of assessing risk. And 4 core principles were noted in this published research in 2007 that we put out that we thought are really fundamental for determining whether a person could be at risk or not. And these 4 core principles were, first of all, suicidal desire. Do I want to kill myself? And do I also have suicidal intent? Am I going to kill myself? Also, am I able to kill myself? It is not easy to kill yourself. So in many ways, if a person has tried to kill themselves before or they're intoxicated, there could be a greater likelihood that they could go ahead and kill themselves. When you have a combination of desire, intent, and capability present, we have a person who's at imminent risk of suicide. If people have buffers or reasons to not kill themselves, those can also mitigate the suicidality. So all of these are factors that help us determine whether or not a person is at imminent risk or not. Now, if they are at imminent risk, what do we do about it? What is our approach to keeping people safe? Next slide, please. So the policy for helping people at imminent risk of suicide who contact us is really driven initially by this safety first value, whereas our primary mission as the National Suicide Prevention Lifeline is ultimately to prevent the suicide of the callers up to the service. We want to make sure that we do everything we can to keep the individual safe. And we recognize the best way to keep a person safe is a shared responsibility. The responsibility ultimately and initially lies with the person who's contacting us. The best way to keep a person safe is to help enable them to keep themselves safe. So the collaboration is critical with the caller. Secondly, we want to make sure that we're collaborating with other services that could be in contact with the caller who could be at imminent risk. Mobile crisis teams, 911, law enforcement, to make sure there's continuing care, respect, and integrity that's provided along the line of this continuous chain of care that's keeping the person safe. Now, there's a number of principles that are fundamental to keeping people safe in our imminent risk response. The first is active engagement, the second is least invasive intervention, and the third is active rescue or involuntary emergency intervention. We're going to talk about each one of these, starting with Eduardo. Eduardo, you want to talk a little bit, if you can, about what active engagement is and where it came from?
I do. Can you hear me?
Yeah, loud and clear.
Yes, excellent. And I am in an airport. I'm on my way actually to conduct training to a couple of dozen 988 providers in the Illinois area on compassion-based, what we call crisis support, as opposed to crisis intervention, and part of this initiative. So really important here. I think, when we talk about active engagement, the notion really gets to who is the person most likely to save another person's life in the event of a suicide emergency. You're going to hear me using some terms that might be a little bit different for you, but I think in our training, Humanivations, we'd like to really clarify. Risk is one thing. A suicide emergency is when somebody is in the act or about to be in the act of killing themselves, attempting to kill themselves. So a suicide emergency is a place where collaboration is still really possible. And actively engaging somebody at risk, includes supporting their experience, not getting into debate, working to collaborate to save a life. And when we approach this from the point of view of collaborative problem solving. I just want to apologize for sound in the background here. All right. Can I still be heard, or is it too distracting? I'm good. All right. Okay. So all of this really goes back to what we know folks on the Lifeline do very well, which is establish caring alliance. And this aspect of authentic alliance is really, really core. Because if we have that, then we can engage the most powerful person in the mix when it comes to saving somebody's life. That is the person themselves. Right? And the Lifeline callers and myself, going back many years, a hotline worker, recognized before we had geolocation, before we had all these things, that's the essence of it. When we collaborate with people, we can engage them, in a meaningful discussion. If we're not afraid of the discussion we can talk about, hey, a question of whether or not I should live through this or why I should live through this is a valid and important element of what's happening for people. What we can do is we can have meaningful conversations when somebody is thinking about taking action to end their lives, and also collaborate to get through today, to engage other resources for support if possible, and really, and even do things, as we know, to reduce access to people's lethal means. So safety planning, can be a truly engaged process. And when we frame it this way, by recognizing, hey, somebody's life is at stake, you've reached out to a crisis support resource. So let's get together and figure out what do we need to do to help you get through today. Next slide. So least invasive is a really important word, and it hadn't necessarily been used that much in our context. But if we think about in the mental health context, where have we been moving away from these highly restrictive, highly coercive practices that not only were sort of shaming and damaging to people, but really pushed people away from what we had to offer. We see least invasive as a kind of a parameter that we want to be talking about. In any given case, how can we make sure that we never step to a more invasive, more coercive approach? We take each step along the way to make sure that when it comes to things like active rescue in an involuntary context, we understand that that is the last resort. We know, as an example, that if somebody is intervened upon involuntarily, all sorts of things might happen that historically, and this goes back to what people said in the way forward, historically felt more like punishment than care. We know when people are having the worst days in their lives, they want care, they can use human connection, they can use support, and particularly if they've reached out for a service, there's a part of them that wants that wants, we believe, that wants to get through this, that wants to stay alive. So peri-intervention risks all sorts of things, including sometimes physically injurious situations, things like police force, etc. And also really risks ultimately the relationship that we establish, this collaborative relationship between ourselves as humans connecting with another human in the midst of intense suffering.
Thank you, Eduardo. Appreciate that. And these are existential moments that our counselors are in the middle of with people who are struggling whether or not to live. And they contact us, if we can go to the next slide, they contact us at times when they are dying or on the verge of killing themselves. And under these circumstances, we do consider 911, but I don't want us to confuse active rescue with calls to 911. Active rescue is not that. Active rescue is actually involuntary emergency service intervention. People often do, and actually more often than not, will tell us, please call 911 for me. These are the circumstances where an individual contacts us, is in the act of killing themselves or saying they're going to kill themselves, and they are unwilling or unable to take actions to keep themselves safe. And so they are calling this suicide prevention service, and our counselors are now in that very difficult circumstance of saying, I need to act on behalf of this individual or they could die. So why would they call us under these circumstances? And then why must we act? A lot of research has been done and has guided our decision-making on this related to ambivalence and suicidality. Tom Joyner, among many other researchers, will tell you that ambivalence in people who are suicidal is experienced all the way up until the time they die. And that is often because of it's really about the pain that they want to stop. It's not necessarily their life that they want to end, but they conflate the two, that there's such a sense of hopelessness about stopping this pain that the only way for it to go away is for their life to end. And this same kind of thinking is in cognitive constriction. We've had a number of conversations with individuals, also in emergency departments, whose last words following a self-inflicted gunshot wound or please save me, or people who've jumped off bridges who immediately after jumping off the bridge, their first thought was, I want to live. Now, when cognitive constriction is occurring, and that is a person is basically in a state of tunnel vision where the pain is so intense that all they can feel and think about is that pain and making it stop, it really prevents one from being able to actively problem solve and see a number of other solutions that could be available to them. So our job is actually to calm them a bit and be able to put them in a place where they can see that light that they're unable to see otherwise. The other thing that's really important for us to consider as we act on behalf of others is we're also acting on behalf of the people that care about them and the people that are not on the call, who will be affected perhaps for generations to come in the event that they die by suicide. Next slide, please. So There's a few other aspects of our imminent risk policy that was published in 2000. Actually, we put it out in 2011 and implemented it in 2012. There's a few things that were not mentioned here. Third-party callers, making sure that we actively engage and collaborate with them. Also, making sure it's a least invasive intervention, making sure that there's 24/7 access to supervisors. Caller ID, not so much a big deal anymore with most people using mobile devices, and confirmation of emergency services contact to make sure that we're actually getting in contact with the people that we think could be dying. Next slide, please. We know that about 2% of the people who contact Lifeline require some kind of 911 dispatch, and most of the time, these are people who are actively consenting to receiving the services. There's even less of the use of 911 for crisis chat, because often the young people who are using it, more often than not, do have parents that can help keep them safe. Dr. Gould did a study on the impact of our imminent risk policy on the practices of counselors and found that it was effective in reducing imminent risk through less invasive means. That means about nearly 3 out of 4 times when a person was at high risk, we were able to de-escalate the issue collaboratively. We've been updating our policy. It's going to be released this year, and I'm going to turn this over to our standards training and practices leader, Shye Louis, to tell you what that's going to be looking like. Shye.
Thank you, John. And if we can move to the next slide. So this year we'll be releasing our updated, what we're calling our suicide safety policy. So the safety policy is going to be a combination and a replacement of the 2007 Lifeline risk assessment standards and our 2011 policy for helping callers at imminent risk. They'll now be merged together. So this policy is also incorporating the concepts that were put forth in our 2019 safety assessment model. So you can see on this first slide, there's some points that talk about some of the things that were included in that safety assessment model that will be becoming moving from recommendation to policy with the release of our suicide safety policy. In addition to combining all of this guidance and our requirements to centers into this single policy, and the supporting background paper, which will be released later this fall, all of these things combined address some fundamental areas that we felt needed clarification or change. In the safety assessment model, so in introducing that framework for folks to think about, the idea is really to give our crisis counselors more resources and tools to help them shift from a focus that some folks get in their mindset about an assessment being a way to predict outcomes or a checklist that they need to complete. So we really know and understand the limitations of suicide prediction instruments, and that those limitations can be profound and not always translate to effective interventions. So in a crisis counseling setting, we're reframing and helping to expand our education for crisis counselors and our training resources for crisis counselors to understand that the focus of an assessment has to be on engagement, collaboration, immediate safety. So determining what supports are needed based on those risk elements that were identified in the conversation, and really being focused on what crisis counselors could and should do with the information gleaned with an assessment to help support, to help build connections, to help create a safety plan. So nothing hugely different, so except for the addition of materials, the addition of support, the addition of training to help really understand that an assessment on a crisis line has to be delivered in a conversational narrative focus, so it's not mechanical or interfering with engagement and negatively impacting those important outcomes from conversations that are often one time. This isn't folks that we're working with as clients, and so we have this one intervention, so we want to make sure that it's focused on hearing their stories and identifying their needs and trying to collaborate on those needs. Additional clarification, if we move to the next slide. Additional clarification that comes on some bullet points here that relate to the importance of training, supervisory review, data collection, and evaluation. So our crisis counselor training, which we will be standardizing and releasing to the network with our first core courses in November of this year. So will be expanded to include the requirements to train around the physical dangers associated with law enforcement interventions for those who are experiencing mental health emergencies. We'll be focusing training on the impact of involuntary interventions to help crisis counselors understand the importance of when they are making that last resort decision. So we'll also be talking about some of the other different kinds of impacts in that training and helping to frame when we need to make that decision, so and what the possible impacts are on that decision of involving any kind of law enforcement or emergency services intervention. We'll also be talking with folks in our policy around a new requirement for supervisory review of all contacts where emergency intervention was used. This is happening in a lot of centers. It's something that we've endorsed so for the entire time, but we're codifying that into policy as we move out this new policy, as well as requiring all centers to collect and report additional data back to the Lifeline on any conversation involving imminent risk. Additional things that are going to be clarified in the policy and expanded within the policy are the importance of community collaboration, requiring all crisis centers to investigate and prioritize alternative interventions so that exist within their community, so that we can lessen the use of these emergency law enforcement interventions that are not happening with consent of the individual, and also expanding centers' requirement to engage with local crisis and emergency services so that when we do need to collaborate with PSAPs or public safety answering points, that those collaborations are as successful as possible. I think we're over time, so I will cut there so that we can stay on track with the overall group, but I will be here and I'll check the chat for questions and try to answer additional ones there.
John and Shye, thank you so much. And I know you'll pass along our thank you to Eduardo as he's on a plane to do some trainings. I'd like to bring forward our roundtable folks, David Covington and Richard McKeon. Richard, are you here?
I am here.
We would love to hear your reflections on the presentation today.
So I'm very appreciative of the presentations that Eduardo and John and Shye have done. I think there are a couple of key things to keep in mind that may not be commonly understood. One is that outside of the work of the Lifeline, there has been virtually no empirical literature on these high-risk situations that would give you a data and evidence-based approach for moving forward. Now, this is important because it means that the default efforts to do what's best for the system as opposed to what's best for people has been unable to be influenced by the current available science. So the work in terms of like Dr. Gould's work on how crisis call centers handle callers at imminent risk, emphasizing the importance of collaboration, I think is, it's really important to understand how much work has not been done in this area. And of course, these kinds of situations occur not only for callers on the Lifeline, but in community mental health centers, all around the country. So I think it underscores the importance of enhancing data and evaluation, as well as oversight and quality improvement procedures when we have these situations where there is imminent risk, and where that risk is not able to be reduced on the call. It also emphasizes the importance when somebody needs to go, that it can be a mobile crisis, ideally without police, responding to that situation. I think that 988 gives us the best opportunity that we have to reduce unnecessary police involvement. But these issues are complex. These are difficult decisions that people on the lines need to make each and every day where a wrong decision in either direction could cost a life. So it is a heavy burden. So I think that the revised safety policy, safety assessment policy will be an important addition. It builds on the core principles that John went over previously. I think my one comment is that I think when you look at imminent risk situations, I think there are two areas. One's fairly straightforward when there's a suicide attempt in progress. Not completely straightforward because sometimes people may disagree about whether something is or is not a suicide attempt. But a suicide attempt in progress, reasonably straightforward in terms of the need to get somebody there quickly, EMS, but it might be the police who are able to get there more quickly than anyone else. But the second area are outside of that realm for those where it's not a suicide attempt in progress. There's a range of situations that do come up where difficult judgment calls need to be made. And I think it's important for us to work toward enhanced specificity around that in our policies and protocols. And there is some excellent work currently being done, particularly by centers that are doing 911 diversion, who have developed such criteria, like Didi Hirsch in their work with the Los Angeles Police Department, who have been able to, and I don't remember the exact numbers, but they've been able to divert from 911 and from unnecessary police response in over 1,000 in the year since it was initiated. Similarly, behavioral health response at St. Louis has a program. Both of these have specific criteria that I think we need to look at carefully to give more guidance to help in our efforts to reduce involuntary emergency intervention to those situations where they are absolutely needed. So those are my thoughts.
Thank you so much, Richard. Always so insightful. Telling us a little bit about your perspective is always helpful. Do you mind? Let's go, David, I hope you don't mind, but we're going to go to Tanja Miles. She's going to be joining us later for her own section, but I just thought you might be able to reflect a little bit on the discussion today.
Yes, thank you so much. I'm excited about this discussion because as I think about my own lived experience and also helping families, navigate through when what was called mine a critical incident. When I look back on my police report, that's what they called it, a critical incident when they respond to me, and how important policies and procedures are to, as we're having this conversation, to put that in place. And I think at the end of the day, it will not only, make it clear for law enforcement, but for everybody that's involved. Someone said earlier about shared responsibility. It is our shared responsibility while we're on that call with that person in crisis and when we're having conversations like this to make sure at the end of the day, what's in place will be best for the person when they're in their crisis to get them to better days. And safety is always first. And look, it kind of triggered me a little bit this week. And when you guys know the young lady that it happened in Georgia, when her mom had to call her because she was having an episode and she was put in the back of a police car in handcuffs and she fell out the car. And so they showed that clip. And I know for me, that was very triggering for so many different reasons, because I remember when my mom had to be called and they had to handcuff her just to take her to treatment, or my uncle. And so, but then if you look at that family member said she thinks it's all her fault because she was the one who had to call 911 and 911 was the only thing in place. So because of 988, we'll be able to change some of that, yes, but then also making sure that we do everything on our end to address every area. Someone else talked about risk, and what that risk looks like for someone who's maybe already had a suicide attempt. I think about zero suicide and how as we connect all the dots, at the end of the day, it's going to be effective when it comes to prevention, to talk about the risk, to talk about safety. And even when law enforcement, look, they're excited that we're having these conversations and policies are being in place because it's going to help them as well, you know, do a better job on what they do and leave it up to the experts and people like us to get to that critical incident, or when a 68 is made with them, they can, you know, refer. So these conversations are needed, and anything that we can do for prevention and put things in place to make it safety first is a win-win for everyone.
I'm so excited that we're going to hear from you also a little bit later today on our new section. So thanks for joining in at the last minute. David, any final thoughts on the feature presentation today?
Yeah, Amy, you know what I would say is it's hard to conceive of how much the field has moved forward under this leadership of a vibrant Richard working with John, with Eduardo, with the research team, with folks like Heather Stokes, who worked before Shye. Before these efforts, it was commonly believed well within our industry, within our field, that maybe call centers, these crisis call centers, didn't add tremendous value. Maybe people who were intent on suicide would not call these, but rather people who were lonely and needed someone to chat. And it was the voice of lived experience and the researchers themselves who listened in on thousands of calls who gave us a more stark reality, which we knew who did the work. And that is that people at significant risk are calling. And yet, as we've begun to move this forward, how do we do that in a loving, caring way, given the risks? And so before this time, it was common to have these policymakers, Laura, you referenced it, all of us in a room, and the voice of lived experience to not be there. Then we started to see an Eduardo or a Dr. Quincy Lazine in the room. But by the time this was being developed, Eduardo convened, it was, I think, the very first meeting I was at, where there are 30 or 40 people in the room. But those of us who are policymakers or providers, Richard, you'll remember this, we were the minority in the room. It was about 70% of the room were people with their own lived experience. So that's really going to keep taking us in the right direction. And then the one other thing I would say that just makes this so much easier is the extent to which Karis was just texting about law enforcement. We want to free law enforcement up to do public safety, and we want to have alternatives like mobile teams that can go out with a peer alongside someone who can do assessment or vis-a-vis the state's requirements. To the extent that that's available, this equation just continues to change.
Wow, what a powerful featured presentation today. And I think the reflections and the comments in the chat just reflect that this is an ongoing conversation, and we have ongoing goals around how these imminent risks calls are handled. Let's turn it next to, yes, buy your t-shirts. I already mentioned that at the beginning. My husband bought his today, so don't be behind somebody who's not even in the mental health sphere. So please buy yours. Go to Crisis Now. They're right there on the front page. All right, next. All right, time for the hot seat. So I'm going to call forward Charlie Smith, Regional Administrator for Region 8, right, Charlie?
That's right, Amy.
Okay,
you got it right.
Wonderful.
Glad to be here.
So happy to see you. So here, and I just want to tell you that I don't want you to feel like bad if you get it wrong, but there were a lot of clues in the presentation today. So here's the question. The National Action Alliance published the Way Forward report in 2014 to create a resource that would convey the voice of suicide attempt survivors, expertly crafted by lead author Quincy Lazine. So the question is, the report identified core values. I can't see without it. Core values to guide helping those at risk, which was not one of the 8. Which one of these was not one of the 8? A, engage in supportive listening. B, provide timely access to care and support. C, promote choice and collaboration. And D, foster hope and help find meaning and purpose. Now we're asking the audience, I'll just tell you, it's always helpful. So shall we see what they said?
Absolutely, Amy. You know, of course, as I remember, I think you being on the hot seat, you definitely went to the lifeline, which is
Oh
the
my
audience. And
gosh.
so
Yeah, it's
I would love to kind of get a sense. I think I know which way to go, but
okay.
I'd
Let's
love
see
to
what
hear
they
what the
say.
audience is saying.
Okay. Here we go. Oh,
Oh my
Charlie,
goodness,
I'm
you guys are
so
really putting me in
sorry.
a
I'm so
really,
sorry. Okay,
really
now I'm
difficult.
just gonna say one other thing before you like crash and burn, because I don't want you to look bad. You can ask one person on the call to weigh in on your choice, or if you feel comfortable, you can choose yourself.
You know what? I'm willing to take a risk, and
I love
clearly
it.
I'm kind of leaning towards the direction that our really split audience is really sitting. I'm actually leaning towards B, which is provide timely access to care, which is not one of those that Dr. Lazine actually included.
Okay, let's go forward and see the answer. Oh, that hurts.
Oh, I missed that one.
Okay,
I think I was so influenced by Eduardo. So
that's okay. That's okay. So I also missed this when we did the practice of it. And what I understand is, and I think what they were talking about on the featured presentation today, is really helping the individual who called take and prepare them to take action for themselves. So provide timely access to care and support, promote choice and collaboration, foster hope and help, and not specifically what, as the call recipient, engage in supportive listening was not included. And of course we do that, but just that wasn't one of the 8 core values. But
well, I'm sorry I missed it, and clearly I'm missing out on the Mega Millions opportunity.
Yes, I mean, I think there was a t-shirt involved, but we might be able to get you one anyways. But I always love working with you. You're such a great support of all the work that we do at SAMHSA and across this country. So thank you so much for joining us today.
Absolutely.
All right. Oh, Karen says you still get a t-shirt. All right, next. All right. Okay, so is Justin Chase here? I'd love to hear from him for a minute. Justin, wonderful to see you. So we know that you're going to join us next week and talk with us, but I'd love for you, just in your own words, to give us a little preview of what you're going to talk about next week.
Yeah, the highlight for next week is really going over 2 aspects of the 988 implementation and the crisis hotline that's been in place for the state of Arizona for a number of years. So in partnership with representatives from a consulting firm that worked with the Arizona State Medicaid agency, we'll be covering an extensive survey that was done regarding crisis line users, stakeholders, agencies, et cetera, to really help inform the state on what is needed as the crisis line evolves over time. And then I'll highlight a little bit on performance and how 988 and the state existing crisis line will continue, and how those will work in parallel moving forward to ensure that regardless of where an individual calls a crisis line, they get the same consistent experience when it comes to accessing the crisis continuum as a whole. So
and I know you were at NASHBIT meeting last week and loved hearing you talk there. And I understand that next week you're going to also bring forward some of these quotes from actual callers who've used the line and help us understand from their perspective, their experience.
Absolutely. I think it's critical. And the discussion we had at NASHBIT was, the first step with 988 is answering the calls and making sure people that the phones are being answered. But the secondary component, the part that keeps me up at night, as do many folks, is the quality there and the level of engagement and support for individuals who are calling, meeting their needs. And our experience in Arizona and Oklahoma really demonstrates that yes, the needs are being met, and we're I'm happy to share a few right now if we have time. Otherwise, I'm happy.
Let's hear at least one. Give us a preview.
All right. So one, the specialist helped me reflect and think through my experience. I've never called the crisis line before, and I'm so glad that I did. And this is just one of many that we've gotten from folks. So.
Well, I'm really looking forward to hearing from you next week, and really enjoyed hearing you at NASHBIT. So we're thrilled to have you on the docket for next week and looking forward to it. Thanks so much for joining us this morning.
Thank you.
So as we all know on this call, there's really high value to lived experience. And we've decided that we're going to add a new section to the call. And we kind of had I think we had a little bit of this last week, I know, because I remember this picture and how kind of, I really loved the visualization of us going together up this mountain. Tanja is going to join us today be our first person to talk on our new section called Lived Lens.
Wow, wow, well, thank you. You know, this is really amazing. This is such a really cool segment of the Crisis Jam, because the Crisis Jam already is so legit. But to have this space as a person with lived experience is really cool. And that just goes to what we were talking about earlier. And I think when you were saying what was addressed when that meeting happened many years ago. And so being able to share my voice, I like to say I was saved to share. That's why I survived to share, so that hopefully it can encourage others. I never forget when I first heard the term zero suicide. I'm just like, that's corky. That doesn't even sound cool. And then I thought about it some more. And then after having my last attempt, it became clear that that can really be real, that can be obtainable. And it is obtainable by what we're doing on this call today and all the amazing work that we're doing. And as I look at this mountain, and I see, you know, crisis stabilization and mobile crisis team and all of that stuff and the vision. And I think it's a song by, I think it's Roger and Hammerstein. It's like climb every mountain, search high and low, follow every pathway. Every path you know, climb every mountain, forge every stream, climb every rainbow till you reach your dream, or something like that. A dream that will need all the love you can give every day of your life for as long as you live. And that's what we're actually doing. We know we're climbing a mountain, we're going to get to the peak, and that's not all. And the fact that, you know, we get to share our lived experience about hope, about healing, about how we know that 988, again, like I always say, is a call for help and connections to hope, and that all of us working together for what we said earlier, because it's a shared responsibility, is really, you know, makes me excited. And I'm just so glad that I survived to share, and given this platform for this new segment of the Jam is the real deal. So I'm super excited, and together we will save lives, and we already are, and we're making a difference.
I just want to tell you that I just soaked in 1/3 of that energy, and it's going to carry me until at least next week's Jam and Lived Lens. So I really appreciate that. And I think, you know, this idea of having the Lived Lens, we've always enjoyed that voice on this call, but to really carve out a section to reflect on where we're going and to help us make sure that the path is, you know, that we're climbing up as many paths as possible to get there. I really appreciate it, Tanja. And thank you for being our first person. That's awesome.
No, thank you. And look, that song, it should be our jam. That should be kind of our theme song. I'm just saying.
Yeah, I like it. You know, David has been looking for a theme song. So I think let's make sure, let's get him on this. All right. So next, we're going to do just a couple round robins on some updates. So I'll turn it over first to John Palmieri to talk to us about SAMHSA's updates.
Thanks, Amy. Really loving the lived experience segment in the Crisis Jam moving forward. So as people have pointed out, obviously taking a moment to reflect on this historic July 16th transition and really building on that momentum to continue to charge forward from the federal perspective. We should be putting forward some data in the upcoming weeks on overall kind of how the system is performing with respect to volume, capacity, and so forth. And this is very much consistent with our desire to be more transparent about data, and also recognizing that this is really just kind of the tip of the iceberg in many respects, as Richard and others have signaled on the call earlier. Really having a robust data and evaluation plan is going to be critical to understand the performance of the system and drive toward quality improvement and equity. And so obviously a lot more work to come in that space. Obviously thinking a lot about our ongoing communications work, certainly post-transition, making sure that we are providing clarity and accuracy around what people should expect when they contact 988, how 988 is different from 911, and understanding the many layers of complexity in those systems and how they intersect with each other, and most importantly, making sure that we're speaking to lived experience through those complexities within the system. I think Richard might have flagged last week that very happy to report that Tiffany Russell from Pew Charitable, who's been on this crisis jam before, has joined the 988 office and is going to be helping us lead a lot of the work on 988 911 coordination based upon her significant experience in this space, and also looking at some of the other partnerships that are going to drive change for individuals in crisis. We are also finalizing our spend plan for the Safer Communities Act. Many of you may recall that we have been appropriated $150 million through that act, and are finalizing our plan, and we'll have more details on that forthcoming. And then also kind of related to that, engaged in work planning for ongoing learning and technical assistance opportunities that will support crisis system development kind of at the national level. So more information on that to come. And then I'll hand it back to Richard in case you wanted to make any other additional updates. Richard?
Yeah, let me mention two other things. Yesterday and today, the SAMHSA and the Veterans Administration have hosted an in-person innovations conference that had actually just ended at noon. And this is working with the governors and mayors challenge teams and sites that we've been working with over the last couple of years. There was certainly a significant emphasis on crisis services. As a part of that, I was privileged, along with Lisa Kearney, to be part of a plenary session reviewing the implications of 988, particularly for our nation's veterans. And actually, as part of that, I attended a workshop that VA had given, which was on the Veterans Crisis Line and law enforcement. And the Veterans Crisis Line has done a lot of work in this space in terms of developing policies and protocols about how keeping people informed and engaged, even when an involuntary intervention is being done, staying on the line with them. And they also have an extensive database regarding 32,000 emergency interventions that have been done over a period of years that can really help inform efforts. What I mentioned earlier is that there's a real paucity of data and evaluation. So the VCL's database is really will be important moving forward. And then the other thing that I wanted to mention is that the Center for Mental Health Services and the Suicide Prevention branch will be 2 weeks from now having a subject matter expert panel on Black youth suicide, which of course has been distressingly rising over the last number of years. And both Brandon Johnson, who's a nationally recognized expert in the suicide prevention branch on Black youth suicide, Walker Tisdale, have been working on this along with many others under Anita Everett's leadership. So those are the two things I most wanted to bring to people's attention.
Thank you, Richard. Thank you, John, for the SAMHSA updates. And I'll turn it over to Brian Sims for the NASHBID update.
And thank you, Amy. And I'll make this very, very quick, kind of give a snapshot here. We'd be remiss if we didn't, as NASHBID, extend our thanks to everyone who attended the recent annual meeting from the 23rd to the 26th of July. We had an incredible turnout, and we even had states and territories represented where people came in from 26 hours one-way flights to attend this meeting, the focus of which was the boots on the ground issue of the 988 implementation. And it was just wonderful with all of the speakers. We're thankful as always to SAMHSA for their leadership and for their support in all of this. And we're looking forward to continuing NASHBID's mission in terms of the importance of really imposing equity and making sure that it is cross-cutting through everything that we do as our priorities in crisis and support services. And I'll turn it back to you.
Thanks. Next. I want you to remember to visit the calculator. Remember that data is our currency, and we need it to be able to get more money and to make the Lifeline exactly what is needed by our customers. So visit the calculator. We'll hear more about it in the coming weeks. Next. Don't forget the Moving America's Soul series. Please visit it. They're just really inspiring movies. And here's what's coming up. You already heard from Justin earlier today. There's no way you want to miss that next week with the kinds of information he's going to be bringing forward about how to have a statewide service, and also the difference between 988 and 911 and the voice of lived experience. So please join us for that. And wait until you see this next slide. You're going to be so excited. Yes, October 5th. Put it on your calendar. Get your party hat. It's going to be our 100th jam session, and I can't wait to see you all there. So make sure that you prepare well and that you're ready to really jam on October 5th. We'll see you all then. And remember, as David Covington told me next week, let's keep running. See you next week. Bye-bye.